Good evening, all the aspirants present here. Today we are going to have the Cardiology Class 2, and the speaker we have here is Varun Pushkarna. So you may start.
Today we will be covering two topics, very important ones: ischemic heart disease and hypertension. So basically, ischemic heart disease is and hypertension, both of them, they make the backbone of whole of the cardiology. Even if an examiner thinks of putting some questions which are with respect to the latest guidelines, the ones that are important, again they will be coronary artery disease and hypertension. Okay, so let's just take the view of it. So basically, ischemic heart disease is defined as an insufficient blood supply to the myocardium due to coronary artery disease leading to supply demand mismatch. Now, it is identified as a spectrum of a disease. So we have on one end of the spectrum stable angina, in which basically what happens is that the patient has a chest pain which is brought upon by exercise or emotional stress or anything that causes tachycardia or increase in the force of contraction of the heart. So both of these things, increase in the contractility or increase in the heart rate, both of them, they increase the oxygen demand, and when the coronaries are unable to meet that, there will be angina. Angina is the left precordial chest pain. So patient will give you the history that the chest pain comes with exertion and it settles with resting. That means it is a chronic stable angina. For example, if the patient says that I have chest pain, it used to settle with rest, but now it is persisting. Now that means it has got converted into an unstable angina. So acute coronary syndrome is another end of the spectrum, which is classified into unstable angina. That means unstable angina means stable angina gone worse. So the same way I told that patient when feels that I sit down, I feel better. But now, even after resting, the chest pain is still there, and there is no evidence of myocardial necrosis. It is still the blood is flowing. There is no 100% ischemia. There is no total occlusion, but there is a decrease in the blood supply. Hence, the chest pain goes for a longer period of time. That is unstable angina. Now, if the occlusion has occurred and it has caused a necrosis of the myocardium, that is known as ST elevation MI STEMI, where there is a transmural necrosis. ST elevation is seen in the ECG. We will look and try to understand which leads are important for those to demarcate the territory involved. Then is non-ST elevation MI, non-STEMI, where there is necrosis, but not full thickness necrosis. There is subendocardial necrosis. So starting from the outwards, it is pericardium and epicardium, myocardium, endocardium, and then the cavity of the ventricle. Starting from the inside, we have what? The cavity of the ventricle, then endocardium, myocardium, and then epicardium. So basically, subendocardial necrosis, there will be elevated troponin. Why? Because there is some necrosis. When the muscle damage occurs, troponins will be released. Unstable angina and non-STEMI, they are differentiated on this aspect that if the troponins are elevated, it is non-STEMI. If they are not elevated, then it is unstable angina. Okay. What is the pathophysiology? Usually, it's a plaque. It's a plaque which is a stable plaque. So a stable plaque causing hindrance to the blood flow. This is the main pathology for angina or a beginning of ischemic heart disease. Imagine this plaque goes on to increase in size, and one fine day it chips off. It chips off, making something look like this. So it has chipped off from this, and this chip has gone and stuck somewhere here. The chip that moved from here, it has got stuck somewhere here. This is called plaque rupture. So the plaque rupture leads to sudden occlusion of the distal blood vessels, and this is the basic etiology of acute myocardial infarction. So it is acute in process. The vascular territories, like we see the heart. So this is the RCA. This is the coronary sinuses. This is left circumflex. This is the left main. This is the left circumflex, and this is the LAD territory. So this is the LAD, this is the RCA. Then there are some branches like PDA is there. So and PDA, the origin of PDA also defines the dominance of the blood vessel. So we have LAD, which supplies the anterior wall and the septum, the right coronary, which supplies the inferior wall and the right ventricle, left circumflex, which provides the lateral wall, and posterior descending artery, PDA. So it supplies the posterior wall, and it can, this blood vessel is used to define the dominance of coronary arteries. Some are right dominant, some are left dominant, some are co-dominant. So that means the posterior descending artery originates from right coronary artery in right dominant vessel, in left anterior descending artery in a left dominant circulation, and from both the major arteries in co-dominant circulation. Is that clear up to now? So coronary artery disease diagnosis is based on presentation of the patient. So number one is clinical presentation. So what chief complaints patient presents with? So usually the chest pain is the main symptom, which is classically retrosternal, and it can radiate to the left arm or to the both jaws. Okay. Associated symptoms can be dyspnea, diaphoresis, and nausea. As far as once the patient has symptoms, the next step to do is get an ECG. So what will you see in ECG? In stable angina, you will either see a normal ECG, or there might be some transient ST depression if you have done ECG in time, or putting the patient on a treadmill test may lead to T wave inversion or ST depression on the stress test. Non-STEMI and unstable angina, you will definitely find ST depression and T wave inversion. The in STEMI, you will find ST elevation. So it will be there, convex or tombstone shape in vascular territories. And of course, reciprocal changes will be seen in ST depression in opposing leads. Now the patient started with chest pain, which was typical retrosternal associated with radiation to jaw or arm and diaphoresis. We did an ECG. We found out ST either depression or elevation or normal. So normal is stable angina, depression is unstable angina, or you can say non-STEMI, and elevation is elevation MI. So what next? You will do biomarkers, blood markers. So troponin I. So what will happen is, if the ECG there is ST depression, but trops are elevated, then it is non-STEMI. If the trops are normal, it is unstable angina. As far as, so we started from chest pain, then it was typical. We did an ECG, some findings. The next evidence is troponins and CPKMB, and the next is imaging. So the next is echocardiography. What you can do is you can get a TMT done. Still you're not sure, you can get a stress echo done, or you can do myocardial perfusion imaging, so on and so forth. Still you are not convinced that the patient has an anginal pain or a non-anginal one, you go for a CT coronary angiography. If the patient wants a non-invasive one, you can go for an invasive coronary angiography, which can be a definitive one and a gold standard, and you can do intervention also at that same time. So you have made a diagnosis of ischemic heart disease. How? The patient had chest pain, you did an ECG, you did troponins, you did a TMT or a stress test, and you made a diagnosis. Okay, you did a coronary angiogram also. You made a diagnosis that my patient has a coronary artery disease or a ischemic heart disease. Now, how do you manage? If it is just a stable angina, that means the pain comes with the exertion and goes away when the patient is resting, then the initial things is blood pressure control, glucose control, weight loss, and stop smoking if they are smokers. Along with that, you give anti-anginals. Now, many people they consider nitrates as anti-anginals only. So the thing is that you have to understand that the anti-anginal is anything which either decreases the demand or increases the supply. So nitrates are related to increasing the supply, but priority should be to decrease the demand. So first line drugs are beta blockers, calcium channel blockers to decrease the heart rate or decrease the force of
मैं भी चल रहा आ रही हूँ
contraction.
ऑफिस
Second line drugs are the nitrates, that is vasodilators, nitrates, nicorandil, and then there are other drugs which are nowadays being projected and indicated to be used in angina. They are ivabradine and ranolazine. If the patient has suffered already an MI and the patient is having a post MI stable angina, then that means you will need to give them aspirin also. So that is called secondary prevention. Primary prevention is that you don't let the MI happen. So you give secondary prevention, aspirin you add on, high dose statins like atorvastatin 18, and remodeling of the heart with ACE inhibitors is mandatory. If the patient still has got chest pain and has not improved with the medical management, then you go for revascularization. Revascularization, the path is through coronary angiogram. So first you do coronary angiogram, either a CT coronary angio or a proper coronary angio. Once you find lesions there, you go forward with PCI. And if it is a triple vessel disease or a critical left main disease, then you will opt for coronary artery bypass grafting. This is for stable angina. Now coming for somebody who has an acute coronary syndrome. So ACS, we remember we defined it on the basis of unstable angina, non-STEMI and STEMI. So immediate management is MONAC. MONAC is morphine, oxygen, nitrates, aspirin and clopidogrel or ticagrelor. That is what is to be given. For non-STEMI or unstable angina, you need to do a risk stratification based on gray score. Once you've done that, you start the patient on dual antiplatelet. Nowadays, the crux is to give ticagrelor by all the recommendation societies. So add aspirin, but the next drug should be ticagrelor or like it used to be clopidogrel. And along with that, you start anticoagulation. Now, this is the difference in management. In stable angina, you never use anticoagulants, only antiplatelets, single antiplatelet, that is aspirin. But in case of unstable angina or non-STEMI, then you will start using anticoagulation along with dual antiplatelets. So aspirin, clopidogrel or ticagrelor plus heparin or fondaparinux. And there is no rush. You can do angiography within 72 hours. So there is no rush in non-STEMI. But in case of STEMI, primary PCI in STEMI is the gold standard, and it has to be conducted within 2 hours. That is the norm. That is the guidelines. And 90 minutes if door to needle time. Thrombolysis, if PCI is unavailable and in third world country like us, thrombolysis can also be done. After the PCI has been done, long-term management is aspirin plus either ticagrelor or clopidogrel for 12 months. Then single antiplatelet agent should be fine. Along with that, all other drugs like beta blockers, ACE inhibitors, statins, and diuretics if the critical muscle mass loss has happened and the patient has developed heart failure with reduced ejection fraction. What are the territories which can be used to identify the blood vessel involvement? So in ECG, if the lead V1 to V4, we will come to the ECGs, don't worry. Lead one, V1 to V4, LAD territory is the projected one, and the tissue involved is anterior wall. 2-3 AVF is classically RCA, and inferior wall is the territory involved. However, in left dominant circulation, it is the left circumflex which drops in a PDA. So it will become the left circumflex can also lead to 2-3 AVF changes. 1 AVL, V5, V6, left circumflex, lateral wall involvement, and V7 to V9, PDA. Although V7 to V9 is not done routinely, but where you suspect that the patient may have a pure right heart infarction, then you need to get V7 to V9 done. All right, let's see few case scenarios. A 62-year-old man presents with retrosternal chest pain lasting for 20 minutes, radiating to left arm. The blood pressure is still 150 by 90. ECG shows ST elevation in lead 2, 3, and reciprocal AVF and reciprocal depression in 1 AVL. See, this is the lead 1. Oh, sorry, lead 2, lead 3, and AVF. And in AVL and lead 1, you see ST depression. So troponins are elevated. What is the diagnosis? What is the diagnosis?
So inferior
Anyone?
wall.
So it is non-STEMI. You must be, first you will classify the infarction. Later you will tell which territory is involved. So it is non-STEMI, most likely inferior wall. Okay. Oh, sorry. I don't know where I was. So it is
Yes.
inferior wall STEMI, and the immediate treatment is PCI, or in where you cannot do PCI, then thrombolysis. So this is how we will proceed. A 55-year-old woman presenting with exertional chest pain. Now, exertional chest pain is classically stable angina. So, exertional chest pain relieved by rest. ECG is normal at rest. Stress ECG shows 2 mm ST depression in V5 to V6. So, थोड़ा सा V4 में भी है, V5 and V6. So, what is the diagnosis? It is a
Stable.
It is stable angina. It is the ECG leads have been brought upon by, you see, they have written ECG is normal at rest, but stress ECG has revealed some changes. So this is definitely lateral wall ischemia, but it is a stable angina. So it is a stable angina with lateral wall ischemia. So you start anti-anginal therapy. My question to everyone, which is the first drug that you will start to this patient?
Beta blockers.
Very good. Second drug?
Nitrates.
Nitrates. Third drug? For secondary
And
prophylaxis?
ranolazine.
No. So third will be aspirin. And fourth will be statins.
Statins.
And if the patient is diabetic, then you will add
ACE
inhibitors.
ACE inhibitors. All right. So this is how the question will come, that which is the most important drug to be started at this time. Usually this is how they ask the question. So these 5 or maybe 4 are the paramount, out of which first 2 are immediate, and also you have to give them advice on sublingual nitroglycerin to be used on PRN SOS basis. Okay. All right. So this is a patient who came with ST elevation MI, anterior wall basically. So this ECG was performed on a 56-year-old man with previous history of drug-eluting stent to proximal LAD, who presented with several hours of chest pain and diaphoresis. Can you appreciate lead 1, V1, V2, V3, some element of V4? So it is basically anteroseptal STEMI. So ECG shows marked ST elevation in all precordial leads. Angiography, you see the cutoff sign here. The LAD could have very well been like this. But you see it is abrupt cutoff here. So this is the why? Because there was a thrombus in the LAD stent. So it was an occluded proximal LAD. And why did the patient develop this? Because the patient was not taking aspirin because of some gastrointestinal procedure. So he successfully underwent a PCI with balloon angioplasty only. We did not need to put a stent here because there was already a stent in place. Okay. So the vessel opened up. Okay. Now this is an ECG that was obtained on a 52-year-old woman with chest tightness and left neck pain who presented with 30 minutes of onset. The patient became hemodynamically unstable shortly after presentation. What do you see in these ECGs?
ST depression in anterior chest leads.
Yeah, so we have ST depression in all the anterior chest leads. Supposedly, if troponins were sent, they were also elevated. So what is the diagnosis here?
NSTEM.
Anastemy
So
involving the
this is an excellent, actually this is an excellent ECG. It's a true RVMI. So what happened is that if you just, how do you actually make it out is that in such a situation with so many leads involved, it cannot be a non-STEMI. So you just lift up and see on the opposite side of the ECG through and through. Like you flip the ECG and see it from the reverse side, you will see it as ST elevation. So these significant ST depression that you note in the anterior precordial leads, they signify a true posterior ST elevation infarct. Okay. So patient was taken up for an angiogram and you see the right coronary artery that could have been like this is abruptly occluded here. Okay. Did you get my point? The true RV, all you see is ST segment depression in anterior leads. Why? Because the RV is placed posteriorly. So either you do a V7 to V9, that is where you will see an ST elevation, or from V1 to V5, if you see ST depressions, just flip over it and see from the other side. So you will see that the patient has ST elevation MI. Okay. This is one diagnosis where it is ST depression, but the diagnosis is ST elevation MI. All right. A 44-year-old male on hemodialysis with type 2 diabetes presenting with chest pain. Now, if you just look at these ECGs, all of them, so when you look at the ECG from a chest pain perspective, maximum marks are given to ST elevation. Maximum marks. So this has to be identified सबसे पहले. If you miss out that the patient does not have ST elevation, then you should look for any ST segment depression. Still, it is also not there, then you should look for T-wave inversion. Still, this also is not there, then you should look for R-wave progression. Now, all these are signs of ischemia. All right. So, now, how many marks will you give to this ECG? Don't look at this. Look at the ECG above only. Can you find any ST segment elevation anywhere? Anyone?
AVR.
AVR, sir.
AVR, sir.
So because there is an ST elevation in AVR, there is ST elevation. So we will give priority to ST elevation. Although there are ST segment depressions also. Can you find them? Can you find ST segment depressions?
V3, V4.
Grade 1, 2.
So V3 to V6,
there
are ST depressions. Now, as I told you here, the most importance is given to which change? The most importance is given to ST elevation. So if I have to ask you ki ST elevation hai or is it an ST depression? So this is an ST elevation MI. But what kind? In left main disease, this is the typical picture. ST elevation in AVR and ST depression in precordial leads. In MRCP part 1, they do not give you ECGs, but in part 2, they will definitely give you ECGs. And identifying a left main coronary artery disease or left main acute MI or left main STEMI. Left main is always considered as a STEMI, and it is also considered as a triple vessel disease. Why? Because left main, if it is occluded, then there are high chances that the patient may go into total left-sided circulation occlusion and the patient may die a sudden cardiac death. Is that okay? So this is a classical left main occlusion. This is a ST elevation MI. This patient will die if you don't take the patient up immediately. So ST elevation in AVR. So what are the other differentials for ST elevation in AVR? What you should consider is number one, global ischemia. ST elevation in AVR can be a sign of left main coronary artery obstruction or severe multivessel coronary artery disease. This is a critical situation because the left main coronary artery supplies almost whole of the left ventricle. Yes, it can also be left LAD occlusion, very proximal LAD occlusion. The moment it originates from the left main, so it may suggest a proximal occlusion of LAD. Rarely it can tell you about the RV involvement in context of an inferior myocardial infarction. ST elevation in lead 2-3 AVF along with ST elevation in AVR may indicate a right ventricle involvement. Rarely, however, non-coronary diseases can also lead to ST elevation in AVR. ST elevation AVR is not a specific finding. After cardiac arrest, in the absence of ACS, it can have a ST elevation in any kind of pericarditis. Interestingly, recently we had a patient of uremic pericarditis in whom the only changes we could see was ST elevation in AVR with V3 to V6 ST depressions and T-wave inversions. Okay? Is that okay? Good. Now, some questions that come from, again and again these questions are asked. Specifically, I kept a slide on it. Absolute contraindications and relative contraindications of thrombolysis. Now, those who have already appeared in MRCP exams, they know that this question will definitely be there in the exam. Every time this question comes. So absolute contraindications to thrombolysis are, number one, any previous history of hemorrhagic stroke. It is an absolute contraindication if somebody had an hemorrhage, intracranial hemorrhage ever. History of stroke, dementia. So when I appeared in the exam way back in 2016, the question that came was pregnancy. Now let's see if pregnancy is a contraindication. Head trauma, brain surgery within 6 months, known intracranial neoplasm, suspected aortic dissection, internal bleeding history within last 6 weeks, active bleeding or known bleeding disorder, any major surgery, trauma or bleeding within last 6 weeks. These are the absolute contraindications. However, relative contraindications are acute pericarditis, oral anticoagulation therapy, patients of atrial fibrillation on apixaban, rivaroxaban, dabigatran. These patients are relative contraindications. Pregnancy is a relative contraindication. So do not make mistake in the exam. Pregnancy is a relative. True and false question may it was there. So pregnancy is a relative contraindication. Within 1 week postpartum is a relative contraindication. Active peptic ulceration is again a relative contraindication. Transient ischemic attack within last 6 months is a relative contraindication. Infective endocarditis, active cavitating pulmonary tuberculosis, advanced liver disease, intracardiac thrombi, uncontrolled hypertension, puncture of non-compressible blood vessel within last 2 weeks, previous STK, traumatic cardiopulmonary resuscitation within 3 weeks. This is relative contraindication. If you want, you can take a snapshot of this page. These are contraindications to anticoagulation. Oh, sorry, thrombolysis.
Sir, we have dementia both as absolute and relative contraindication.
Yeah, I'll tell you why. So
Okay, sir.
dementia is also many types. In case it is a multi-infarct dementia, it is a contraindication absolute, because multi-infarct dementia can bleed anytime. If it is an Alzheimer's disease, you can still thrombolize the patient. So stroke-related dementia, history of stroke and dementia, no, that is the dementia secondary to stroke, multi-infarct dementia that we call. Okay.
Thank you, sir.
Dementia as such, the degenerative disease of brain, that dementia that does not appear as a absolute contraindication, because there is no demarcation between both. That is why both of them are kept in contraindications, because you never know if an Alzheimer's also had a stroke. Is that okay? Taken the photo?
Yes, sir. Thank you, sir.
Okay. So now we will do some MCQs with respect to ischemic heart disease. So a 60-year-old male presenting with chest pain and dyspnea, ECG shows ST elevation in V1 to V4. What is the most likely coronary artery involved? Easy questions.
LAD.
LAD.
LAD. Cool. So LAD. A 70-year-old man with non-STEMI has a gray score of 150. What is the next step? So we actually did not cover the gray score. So we would like to go for invasive angiography within 24 hours. So anything which is more than 140 gray score, this patient requires urgent invasive strategy. Gray score is basically developed to match the STEMI scores. So if the patient has STEMI, we would like to immediately intervene and put a stent in the patient. But as far as non-STEMI is concerned, earlier the guidelines were that you have to just do the angiography before discharge, because the management of the patient is basically purely based on anticoagulation and what you call antiplatelet therapy. But eventually what happened was we realized that the patients who have non-STEMI and we discharge them without doing an angiogram, they have a very high incidence of post-MI angina. So the gray score was introduced, and anything more than 140 is defined as high risk indicator for adverse outcomes. A 45-year-old woman develops chest pain at rest. ECG shows ST elevation in lead 2-3 AVF. Troponins are negative. So what is the diagnosis?
Prinzmetal.
NSTEMI.
NSTEMI in ST elevation.
Oh, no. Sorry.
Prinzmetal. Variant angina.
Yeah. So young females around 40-45 years of age, they can have a condition known as coronary vasospasm. Now, this coronary vasospasm can manifest itself as ST elevation because it's a coronary spasm, no? So eventually the body feels as if there is no blood flow going to the coronaries. So it is a Prinzmetal's angina, variant angina, transient ST elevation with normal troponins. It literally presents as an ST elevation MI, but troponins are negative. You do a coronary angiogram, it is entirely normal, absolutely normal coronaries. Okay. A 65-year-old diabetic male is on a perfect medical therapy for stable angina, but still continues to have symptoms. What is the next best step? So what will you do in this case? Patient is on maximal therapy. Patient is on good dose of beta blocker. Patient is on good dose of nitrates. Patient is on aspirin statins, but has exercise-induced angina still present. There is this excellent drug called ranolazine, which is nowadays, along with ivabradine, is approved to be used in kind of a refractory angina. So the answer here will be to add ranolazine. So ranolazine is an effective add-on therapy for stable angina when initial therapy fails. All right.
Sir, good evening.
Good evening.
Could you give a small gist on ranolazine if possible, sir? A very small gist on ranolazine, something about the drug if possible, please.
Yeah, sure. So
Thank you.
basically, yeah. So along with that, I will give you the gist of ivabradine as well along with. So
Thank
this
you.
is ranolazine is basically a second line anti-anginal. So we already have known that the first line anti-anginals are nitrates. So ranolazine is basically a sodium current inhibitor. Mota mota that I remember is that it is a sodium channel blocker. So this ranolazine. So it's a second line anti-anginal. It blocks the sodium channel and hence it also blocks the calcium load inside the myocardium. So depletes the calcium, leads to decreased contractility, hence leads to reduced angina. Okay, so it is indicated in chronic stable angina when the patient has failed beta blockers, calcium channel blockers, and nitrates. There were a few contraindications also. I think long QT syndrome, ranolazine is contraindicated. So why? Because it itself, ranolazine causes prolonged QT. Why? By decreasing calcium inside the myocardium, the repolarization phase is elongated. That is important. So torsades, des pointes, this can occur. Okay. As far as ivabradine is concerned, so ivabradine is an excellent drug. It is now used right and left because it is approved not only in angina but also in the management of heart failure. So it is funny current inhibitor. It is basically sinus node ivabradine. So nowadays it is approved to be used in stable angina. Again, second line drug, stable angina, and in heart failure with reduced ejection fraction. This is very important. So there are certain currents in the SA node which are known as funny currents or IF. So these are funny currents in the SA node which can lead to persistent heart rate increased. So despite beta blockade, good calcium channel blockade, you are still getting the tachycardia or the higher heart rate. So ivabradine is indicated where with maximal dose, you are unable to get the heart rate below 70. Okay. So its indication are chronic stable angina, and so the drug is to be started at 2.5 milligram BD. Ranolazine is to be started at 500 milligrams BD. So these are the only usual indications and usual things that I can tell you about them.
Thank you, sir.
Yeah. So, for example, let me just give you two case scenarios also along with, because that is what we are here for. So let us say we have this male only. Similar question I like to put you. So we have this patient who is a 65-year-old male with chronic stable angina, type 2 diabetes mellitus, plus mild renal impairment. And the patient is already on amlodipine, 10 milligrams daily, metoprolol, 200 milligrams daily. His BP is 130/60, heart rate is 65 per minute, and ECG is normal. But patient continues to have angina. So this is how they will just mold this question. So what is the next best step? So the answer will again be ranolazine. Now I say that the ECG shows QT interval of 520 ms. Which is the next best drug that you will use?
ivabradine.
Wonderful. So now the answer will change. For the same question, it will become evaporated. Or they will say the ECG has nothing but echocardiography shows ejection fraction of 35%. What is the next drug to be used?
Same.
Again,
Evaporating.
Again, evaporating. So just by changing one line, we can change the approach. So ranolazine is indicated in angina, but when it comes to angina with heart failure with reduced ejection fraction, the drug becomes evaporating. All right? Is that okay?
Yes. Doctor, in the above question, what you had told the scenario, can
Yeah.
nitrates be also given as an option?
Yeah, of course. Sorry, I missed. I was focusing on the beta blockers and calcium channel blockers. So NTG 6.4 milligrams BD twice daily. So already on the highest dose.
Thank you, sir.
Yeah. Basically, we have to create a situation where the mind runs towards looking for something more. So that something more should, at the end of the day, should help the patient, not for something which can be troublesome. So we should just know the indications. We should just know the indications of which drug to be used when. Okay. Now coming to hypertension. So by NICE guidelines, the blood pressure of more than 140/90 at home or at clinic more than 135/85 is hypertension. Now they've classified hypertension on the basis of these values into stage 1, 2 and severe hypertension. Stage 1 is when the BP is between 140/90 to 159/99. Stage 2 is anything above 160/100. Severe hypertension is systolic more than 180 and diastolic more than or equal to 120. There are two types. One is essential hypertension, which is usually the case. 90 to 95% of the people have essential hypertension. Secondary hypertension, only 5 to 10% people where it is something else causing it, like pheochromocytoma, like renal vascular stenosis, or polyarthritis nodosa. So things like that, they have to be found out. What is the pathophysiology of hypertension? Number one, there is high cardiac output influenced by blood volume and myocardial contractility, along with increased peripheral vascular resistance, which leads to due to vasoconstriction and vascular remodeling. The important key factors to understand in hypertension are number one, renin angiotensin aldosterone axis, because everything that we are inventing these days, we are using these days, we are trying to manage and manipulate these days is this system only. Second is sympathetic nervous system overactivity. So meditation, yoga, pranayam, these are the things which control that part. Then is definitely endothelial dysfunction, cigarette smoking, presence of dyslipidemia, hypertriglyceridemia, and so on, diabetes mellitus. So these are the agents causing endothelial dysfunction. So all of them are contributory factors to control and poor control of hypertension. There are certain risk factors like age, genetics, ethnicity, being Afro-Caribbean individuals, which cannot be altered. But then there are other ones like overweight, obesity, sedentary lifestyle, increased salt intake. These days, alcohol is also included in the list of modifiable factors, cigarette smoking, stress, anxiety. So these are all again included in the outcomes of hypertension. So how do you diagnose? We've already discussed that the levels anything above 140 by 90 is the clinical blood pressure is hypertension. But just like in diabetes, we used to say two fasting blood sugar levels more than 7.1 done 14 days apart. And later on, HbA1c came in and we say anything above 6.3 is diabetes. Anything 5.7 to 6.3 is pre-diabetes. Same way, you have to diagnose. So to diagnose, what is that you are expected to do is confirm the BP with ambulatory BP monitoring. Now, unlike in India, where if the question is asked, we may not have an answer. But in UK, as far as MRCP exam is concerned, if you need to diagnose hypertension, you have to confirm the readings via ambulatory BP monitoring or HBPM, that is home blood pressure monitoring, if the clinical readings are elevated. For accurate measurements, one should use a properly calibrated machine, and patient has to be seated for 5 minutes, arm at heart level, and either of the two arms, whichever arm feels or measures higher blood pressure, that is to be counted. Okay. So if one shows 160 by 90, the other shows 140 by 80, 160 by 90 is to be taken into account. Once you have made a diagnosis of high blood pressure or hypertension, you should always assess for end organ damage. Which tests to be ordered? A fundoscopy to rule out hypertensive retinopathy. Number 2, ECG with LV hypertrophy. Number 3, some blood tests like urinalysis, like EGFR, like lipid profile, like HbA1c. And then urinalysis, of course, to check for any proteinuria or hematuria. So these are always done to rule out any potential organ damage. In young adults, less than 40 years of age and refractory hypertension, in people who you are unable to manage the blood pressure, you should always rule out secondary hypertension. Usually in kidney patients, in renovascular disease, in primary hyperaldosteronism, PHO, Cushing's, thyroid dysfunction you can find, or structural heart disease like coarctation aorta, and then of course obstructive sleep apnea. You should always rule out these in young people and in refractory cases. So how do you manage? First is obviously lifestyle modifications for everyone, reducing salt intake to less than 6 grams, physical activity to more than 150 minutes per week. These are very important, the units that I have mentioned here, because they are always in the true and false statements. Weight reduction to BMI less than 25 and limiting alcohol to less than 14 units per week. Stopping smoking, and of course DASH diet. Stepwise approach. So the algorithm is very clear that once somebody is known to be diagnosed as hypertension, you should, number one question you should ask is, do they have diabetes or not? So hypertension and hypertension plus diabetes. Then they ask question if they are less than 55 years of age, non-black, or more than 55 years of age. So the first line treatment for anybody who is less than 55 years of age and non-black is ACE inhibitor and hypertension with diabetes also. So these are the patients where initial drug of choice will be ACE inhibitor. Just hypertension and age above 55 years, the drug of choice is CCB. So if you are unable to control the blood pressure, just combine them together. So for ACE inhibitor, add a CCB. For CCB, add a ACE inhibitor. Then comes the third drug. Third drug is these hydrochlorothiazide or thiazide like diuretics, and the fourth drug is add spironolactone if potassium is less than 4.5. If it is more than 4.5, you can go for either beta blocker with antihypertensive control, that is carvedilol, bisoprolol, nebivolol, or you can use alpha blockers like prazosin. Okay. So these are the guidelines and stepwise approach. So BP targets are 140 by 90 and below for most adults. For diabetics, it is 130 by 80. Hypertensive crisis are two: urgency and emergency. Urgency is severe BP elevation like 180 by 120 without end organ damage. So the onus on us is to gradually reduce the blood pressure with oral agents. If the severe BP is elevated with acute end organ, like patient is confused, patient already has chest pain or weakness of some limb, then you should immediately go with IV agents and immediate reduction is to be done. Now, case scenarios: a 55-year-old male, cutoff is 55 only, and 55 it is. 55-year-old male comes to clinical blood pressure of 150/92. Home blood pressure monitors confirms BP of 142/90. So diagnosis of stage 1 hypertension is established. No end organ is found. What is the most appropriate next step? So answer is lifestyle modification and start antihypertensive therapy. A 60-year-old Afro-Caribbean woman with hypertension is on amlodipine but remains uncontrolled. So BP is 155/96. What is the next step? You will add a ACE inhibitor or ARB. So add a ARB or losartan. Case 3. A 35-year-old male with severe hypertension presents with headache and blurred vision. Examination reveals bilateral papilledema. What is the most likely diagnosis and next step? So what is the diagnosis?
Hypertensive emergency.
And what is the treatment?
The labetalol or
Yeah.
IV drugs should be given.
Intravenous drugs and admitting to the hospital. Okay. A 45-year-old man with newly diagnosed hypertension has a blood pressure of 148/96 on ambulatory BP monitoring. So this is diagnosis is correct. Hypertension. Yes. So ambulatory BP is 148/96. What is the diagnosis?
Primary.
Stage 1 hypertension.
Blood tests show potassium of 2.8.
Primary hyperaldosteronism. Neurolocorticoid excess.
So what is the most likely diagnosis? Renovascular hypertension, primary hyperaldosteronism, FEO, or essential hypertension?
So primary hyperaldosteronism.
Yeah. So it is a young man, 45 years old with hypokalemia. So the answer is primary hyperaldosteronism because hypokalemia with hypertension is suggestive of hyperaldosteronism. A 62-year-old diabetic patient with blood pressure of 150/88. According to the NICE guidelines, what should be the target BP for this patient?
Less than
130/80.
130/80.
So let's go back to the slide. Yes, 130/80. This is the slide. Blood pressure targets for patients less than 140/90 for most adults, 135/85 for home or ambulatory readings, and 130/80 and below for diabetics and those with end organ damage. So the answer here will be less than
130/80.
a 70-year-old male on indapamide and amlodipine has uncontrolled blood pressure of 160/90. No other tests have been given to us. What is the next best step? Add spironolactone, add ramipril, switch to beta blocker, or refer to secondary hypertension. Hanji. So
Ramipril has to be added for this patient.
So basically your answer is correct, but I think while I was there is some mistake when I was making this question. No, this patient is on telmisartan. So this patient is on telmisartan, indapamide, and amlodipine, and has a uncontrolled BP of 160/90. What is the next step? So the answer will be
Spironolactone here.
yeah. So the answer will be spironolactone. Before that, if something has to be filled and is there in the answer is to check serum potassium levels, and if before that also to check for compliance. So in a 70-year-old man, what can go wrong with compliance is that the patient had a dizziness, had a tendency to fall, and he stopped taking medication.
Hmm.
So these are the things that are actually challenging in cases of people who are elderly, living alone, and are on multiple medications for blood pressure control. So
So here, if option C was add beta blocker instead of switch to beta blocker,
see, if the by nice
I'm
guide,
saying that
if you go by the nice guidelines, no,
G.
then step one is either calcium channel blocker or ACE inhibitor. Step two
Right.
is combine them. Step three is add a thiazide diuretic. Step four is to
Is
add
there
a
beta blocker?
it is to
Beta or
add
an
a
alpha blocker?
spironolactone. Step five is to add a beta blocker or a
Alpha blocker.
alpha blocker. So
Okay.
before going for a beta blocker, I would like to exhaust spironolactone.
Right, sir.
Okay. All right. That was the session for today. If there is anything left, we can cover it in the next class if we can have.
So what topics are you plan to discuss in the next class, sir?
We can discuss cardiomyopathies, all of them, restrictive, constrictive, dilated,
G.
in the next class, along with, have we done arrhythmias? We've done stroke. Okay, we'll do arrhythmias and cardiomyopathy.
Okay, sir.
Okay, bye. Thank you.
Okay,
Yeah.
I have
Thank
a
you.
announcement to make, everyone. So we are organizing a 3 days spaces program in Kolkata KPC Medical College. All the aspirants can join us. Also, there will be all the MRCP faculty present with us, along with Dr. Varun Pushkarna. If you want any details regarding that, please do reach out to me. I'll be happy to share it with you all. Thank you.